So this is again the scheme of my talk. Oh, it doesn't work now. Why? I cannot progress.
Is that your last slide?
Okay. No. Okay. So this is all the topics I will go through. Just to remind you that we have actually three types of seeding: the dust, the spheres, and the clouds. I will go back to that because it has importance in terms of how you treat and the number of cycles you give. Now, when it comes to intravitreal chemotherapy, it's important to just realize what we are targeting. We are targeting both vitreous seeding, which is just migration of tumor cells in the vitreous cavity, but we are also, with a similar efficacy, targeting sub-yelloid seeding, as shown on the inferior part of the screen. And as you know, this is actually a cloud in the sub-yellow space, blocked by the vitreous base at the margin, as you can see here on the bottom right image, Fudos image. Now, and you have two examples here. One is on the left, the seeding in the vitreous, and on the right, it's a cloud in the vitreous, but you have also a sub-retinal seeding with actually seeding covering the optic nerve head. So I am a fan of two particular tools, and I think they are extremely helpful in the management of these cases. One is OCT, as already highlighted by Santosh and Karp, and ultrasonic biomicroscopy. So I'm using the Flex, idle Flex, which allows you to perform the OCT in a supine position. And I have the Aviso for the 50 megahertz OCT, UBM, sorry. So of particular interest, OCT is to diagnose and monitor the epipapillary seeds. We have detected tens of such cases, and usually the seeds on the top of the optic nerve head or in the cup, optic cup, are invisible seeds. And if you don't detect them early enough, they will start growing in the cup, and then you cannot get rid of this seed just with intravitreal injection. You will have to also add intra-arterial chemotherapy. So this is of importance. It's also important to monitor the seeding response to intravitreal chemotherapy. We do see in this following injection in the vitreous a fragmentation of the seeds and an increase of reflectivity, which is typical of a complete response, allowing you to stop injecting in the eyes. Now, regarding ultrasonic biomicroscopy, I think it's very important to be able to detect a trans-yelloid migration of the vitreous seeds. And we have seen this also tens of times. And of course, your therapeutic strategy will be totally different if you have seeds in the aqueous. Now, I will not put too much emphasis on the technique. It's well known and adopted widely, consisting of an anti-reflux procedure with cryocoagulation of the anthracite to destroy the tumor cells. Now, here's my regimen, a number of injection for dust. I do now 2 injections. So I reduced a lot compared to my initial paper where I used to inject the double of injection for this. And for spheres, 3 injections, and clouds, 4 injections. We have actually 2 drugs at disposition to do that. We can combine them also in case of resistance. Carol was the first to combine these 2 drugs for resistance vitreous seeds. For melphalan, we have at present 2 specialties on the market. Alkeron, the historical one, and Evomela, which is also melphalan, but without the alcohol, without the propylene glycol that is used to dilute, to prepare the solution for the injection, and the topotecan. So this is the type of result that we can obtain, of course, combining here, of course, also with intraarterial. Here, a double cloud, a cloud under the yelloid and a cloud in the vitreous. Final result, he had detachment at some point. We had to buckle the eye. These are other examples of success that we can reach with a combination of intravenous and intraarterial chemotherapy. Now, I will touch briefly this. Efficacy, it's close to 100%, honestly, with melphalan. Using the appropriate dose, we are now close to 1,000 injections in more than 200 eyes. And I had probably 2 eyes only where I had to combine with topotecan. This is also this unprecedented efficacy has been also reported by a group of Carol and also in Los Angeles. Now, topotecan, we don't know presently if this is equally efficient as melphalan, but we have very good news from India, actually, because Santosh Group and Dr. Rao published 2 years ago, complete response is 17 eyes, in all the 17 eyes injected with topotecan, which is a very promising result. Now, what about toxicity? We are dealing with severe, potentially severe and sight-threatening toxicity caused by this melphalan-induced retinopathy in some 40% of the eyes. It appears that there is virtually no retinopathy caused by topotecan, but this is also a little bit early to know for sure. Now, in Europe, we have a European Retinoblastoma group launching this prospective international phase 2 trial, randomizing melphalan and topotecan for intravitreal retinoblastoma, and will hopefully answer the question of the efficacy, comparing efficacy and the toxicity. Now, I come back shortly because it's a big concern about retinal toxicity. So we can grade this toxicity 1 to 5. 5 is a total, I would say, retinal necrosis with panretinal reaction. I think there are 2 things that are very important to keep in mind, limiting, if not avoiding, the severity of this toxicity. One is to avoid what I call the paravitreous injections. I will just come back to that in a second. And secondly, to keep the effective intravitreous concentration lower than 10 microgram per ml. So this is pictures that I owe to Tero Kivela, who treated a newborn for this papillary tumor in the macular papillary bundle, and injected in the vitreous just behind the lens, and caused this devastating necrosis of the retina just at the back of the eye. And this is because of the injection in the Clockett's canal. Similarly, if you have a big retroyellow space, and believe me, if you perform ultrasonographic 10 megahertz ultrasonography in your patients, you will notice, and all my colleagues will agree with me, that virtually all patients have a posterior yelloid detachment. And if you happen to inject in the retroyelloid space, you will end up with a huge concentration and devastating effect on the retina. Now, regarding the importance to give the appropriate dose and to keep it at a secure level, you have to take into account two things: the growth of the child, so the age, and you have to take into account the residual tumor volume. As you know, it can vary from if you have type 4 regression with flat scars. So the vitreous volume is just equal. There's no reduction by the tumor. But if you have calcified tumors, big calcified tumors, they can influence quite significantly the tumor, the vitreous volume, and thus the dose you're supposed to inject to have the appropriate dose. So we have calculated this, and we have found that if you want, I've summarized that. This is on the left, the ABAC for type 4 regression. What you want is to keep the concentration, the effective intravitreal concentration between 6 and 9 microgram per ml to avoid, to have efficacy, at least 6, and to avoid severe toxicity at the retinal level, so below 10. And this is for type 4 regression, and this is on the right for tumor volume, residual tumor volume in the eye of 25%. So it's shifting, of course, the curves. And then I have summarized the advised dose you have to inject according to age and residual tumor volume. So in summary, regarding my guidelines to reduce toxicity, always perform a 10 megahertz ultrasonography to document the yelloid status. Do the paracentesis systematically under the microscope. This allows you to inject bigger volume in the vitreous and to use lower concentration and a better distribution of the drug. I use 33 gauge needle, 12 millimeter long, at 3.5 millimeter from the limbus, usually 3.5. If I have a newborn, I will go to 3, but never below, to avoid the complication at the level of the lens of the intersegment. And a long needle, which allows you to position the tip under the operating microscope just behind the lens, in the center, far from the eye wall again, because you want to avoid the retinal toxicity and the toxicity at the level of the iris, to avoid uveitis, to avoid intersegment side effects, to avoid also paravitreal injection. And this can be simply obtained by observing the cloud formation under the microscope. If you inject slowly, you will see very clearly. If you focus correctly, you will see your solution forming a cloud in the vitreous. For small eyes with actual lengths of 19 millimeter, prefer 20 over 30 microgram of melphalan. Prefer also a meridian with a pre-existing chorioretinal scar. And importantly, re-inject at the same meridian to prevent retinopathy extension. So you have more details in this publication that we just made in this journal, and I thank you for your attention.
Thank you.